Hi, everyone, and welcome. It's 1 o'clock, and I see a number of you have joined us already, so welcome. I think we'll get started. Thanks to everyone who's joined us today for the third CaDeN Community Champions webinar. My name is Jenny Herbin, and I'm the Community Engagement Coordinator at the Canadian Deprescribing Network. For those of you who are new and who may not know us yet, the acronym we use for the Canadian Deprescribing Network is CaDeN, and you'll be hearing this acronym throughout the webinar today. The CaDeN Community Champions webinar series is about bringing people together across Canada who are championing medication safety for older adults in their communities. Today, we're shining the spotlight on some great work that's being done around medication safety and deprescribing in Nova Scotia. Now I'd like to welcome our three guests on the line as presenters and panelists today. We have with us Dr. Andrea Murphy, Bill Berryman, and Dr. David Gardner. They'll be talking about their initiatives to raise awareness and create change around medication use in Nova Scotia and beyond. So first, Dr. Andrea Murphy is a pharmacist and associate professor in the College of Pharmacy at Dalhousie University, cross-appointed with the School of Nursing and Department of Psychiatry. Andrea, would you like to say hello?
Hi, everybody.
Thanks. Great. Bill Berryman is the president of the Retired Teachers Organization of the Nova Scotia Teachers Union. He was also recently elected as president of the Canadian Association of Retired Teachers and is chair of the Group of 9 Seniors Advisory Council of Nova Scotia. Hi, Bill.
Good afternoon, everyone.
Thanks. And we also have Dr. David Gardner on the line. He's a pharmacist and professor in the Department of Psychiatry at Dalhousie University and has a joint appointment with the College of Pharmacy. Both Dr. Murphy and Dr. Gardner are executive members of CaDeN, and they've co-developed several programs aimed at helping the public access resources and care, particularly in the area of mental health, and at enhancing the role of community pharmacies in supporting mental health and well-being. Hi, David.
Hello, how are you?
Great, thanks. Okay, so please hang in there, everyone, if this isn't the first time you're with us hearing this, but I know we do have some new attendees on the line, so I'd like to give a brief overview to make sure everyone is comfortable using the technology. For those who've joined the webinar by computer, you can follow the presentation visually and see the PowerPoint slides. The panelists and myself are currently speaking over the phone line, so if at any point you have trouble hearing us from your computer, I would recommend also connecting to the webinar by calling in using the phone number and webinar ID, which is in your registration confirmation email. And we'll also put those call-in details in the chat box shortly. So at the bottom center of your screen, you'll see a button that says chat. If you move your mouse over that button and then click, a chat box will open up. This chat box is how you can communicate with the panelists and myself today. If you experience any technical issues during the webinar, please don't hesitate to write us a message in the chat box and we'll try to help. You can also select who you would like to send your message to in the chat box by clicking on the drop-down menu next to the To field, which is just at the bottom of the chat box. When you choose To All Panelists, as opposed to To All Panelists and Attendees, only the presenters and myself can see the questions, which brings a certain level of anonymity. We will have time for your questions for our panelists during the final portion of the webinar today, and I would ask you to please save your questions for this time. The chat box is the perfect place where we'd welcome you to ask these questions. Your phone lines have been muted for the time being. This just helps us eliminate background noise. And this webinar will be recorded and put online in the next few days. We will send you the link, which we'd encourage you to share with those in your communities and networks who weren't able to join us today. So that about covers it for the technical functions. Now we'll move on to the meatier part of our webinar today. We'll start with a presentation from Dr. David Gardner on insomnia, sleeping pills, and tools available for getting a good night's sleep without sleeping pills. This segment will be about 25 minutes in length. And during the remaining 20 minutes or so, we'll have a panel discussion and we'll get to ask Dr. Andrea Murphy, Bill Berryman, and David our questions about their experiences supporting the well-being of older adults in Nova Scotia. So David, I'll hand the floor over to you.
Okay, well, I will take the floor and I will try and share my screen. So that'll just take a second.
Great.
And here it comes. All right, I see what I'm trying to share. Can you see what I'm trying to share?
I can see what you're trying to share.
Yep. Great. So thank you, Jenny, for inviting us to speak about some of the things that we've been doing here in Nova Scotia. So Andrea and I have been working on SleepWell sort of as a project for a number of years now, but it's gone through a refurbishment, if you will, in the last several months. So it looks a little bit different. It used to be called SleepWell NS, as in novascotia.ca, and our new website is mysleepwell.ca. It's really a pan-Canadian effort. It's intended to be for anybody who is having trouble with insomnia per se and needs to get some help and is not necessarily interested in just sticking with sleeping pills. If you're not taking sleeping pills and you have insomnia, SleepWell is helpful. If you have insomnia and you are taking sleeping pills, whether you've just started or you've been taking sleeping pills for 10 years, SleepWell will be helpful. So the idea really for SleepWell is twofold: to help people who have insomnia and to help people who have been taking sleeping pills for a long period of time. So we've had the fortune of coming across Bill through these efforts and other Nova Scotians who are helping us improve SleepWell. So I'll take you to SleepWell, the website, a little bit later. And what you see today won't be what you see in a month's time. It should be getting better and better. So we welcome people to come to mysleepwell.ca on several occasions and see what useful resources and tools are there. So before we get to that, I'm going to have us go through just insomnia really briefly and then talk about sleeping pills themselves for a little bit. And then we will get into something that is called CBTi. It is the best treatment for insomnia that nobody's ever heard of. So I'll help to introduce that to everybody who's online with us today. And then at the end, just give a quick overview and orientation to the website itself. So our sleep architecture changes as we get older. Babies and adolescents have very different sleep architecture. Young people in their younger 20s have quite different sleep architecture than somebody who's 80 years old. What's shown here is the sleep architecture of a typical adult and of a typical person who is possibly in their 75th, 80th year. And you can see a dramatic difference in sleep architecture. Stage 3 and stage 4 is what is referred to as deep sleep. And people think of that as that really restorative sleep. When you're a young adult, you experience more deep sleep than when you're an older adult. When you look at the top of the graph, it says awake or REM or stage 1 sleep. So lighter stages of sleep where you actually pop out and wake up in the middle of the night. So if you look across the hours of sleep of the young adults, that person may have had very brief awakenings a couple of times in the night, whereas the older adult looks like they've had very many awakenings. Some they'll remember and some they won't. Some are very short and some last a little bit longer. What's really important to notice here is that these changes are normal. I'm not showing that somebody has healthy sleep in the top and unhealthy sleep in the bottom. Both are considered healthy, normal sleep, and they're just a reflection of the normal expected changes with aging. What is insomnia? Well, everybody knows what insomnia is because almost all of us have experienced insomnia, but there is an official definition of it, which is the dissatisfaction of the quantity or quality of your sleep It tends to be most commonly that you can't get to sleep, but sometimes it's difficulty maintaining sleep, or something that we call early morning awakening. Some people experience more than one of those, so it may be that they have trouble getting to sleep and then they wake up often in the middle of the night, or that they have middle of the night awakening and then early morning awakening and they can't get back to sleep. We tend to see it a bit more often in people who have physical conditions like pain, for example, fibromyalgia or other physical conditions, and also more often in people who have anxiety disorders or other psychiatric illnesses, maybe depression and so forth. There are terms like short-term and chronic insomnia, or something called insomnia disorder. So chronic insomnia or insomnia disorder is that you experience difficulties and dissatisfaction with your sleep. There are daytime implications of fatigue, tiredness, irritability, difficulties with your performance during the day. You experience those 3 days a week or more for 3 months or longer to be defined as having chronic insomnia or insomnia disorder. And if it's less than 3 months, then it's called brief insomnia disorder or short-term insomnia disorder. So that's just a really quick overview of insomnia. Now let's turn our attention to the sleeping pills themselves and ask the question, how effective are they? So do you recognize these all as sleeping pills? And some people would say yes, and some people would say no. I tend to be rather inclusive. If somebody is using cannabis every night to fall asleep, that falls under a substance that's being used to help somebody sleep. It may not be a pill, but really it's serving as the same purpose as a sleeping pill. Same with alcohol, same with other natural remedies like L-tryptophan, valerian, melatonin. But what people often think about as sleeping pills are those that are prescribed, a little blue pill by the doctor called zopiclone or imivane, Ativan or lorazepam, Cirax or oxazepam. These are the benzodiazepines, or the Z drugs, which really work very similarly, and to my mind, they work the same. Their mechanism of action is the same. Another mechanism of action is with diphenhydramine, which is an antihistamine. So people who take antihistamines that they get over the counter at the pharmacy, they may be taking it for the purpose of falling asleep at night. Take it a half an hour before you fall asleep, before you go to bed. And for a few nights in a row, it might be helpful. But after that, it probably stops helping. There's an older antidepressant called amitriptyline. And then there's something called quetiapine. And this has become, has caused a lot of talk in the last few years because quetiapine is an antipsychotic medication. First approved worldwide for the treatment of schizophrenia, then used in bipolar disorder, then some studies suggested it has some antidepressant effects, so the management of depression, and now it's being used to help people sleep. So we're using a rather potent medication with a rather complex pharmacology for its antihistaminic effects that induce sleep. So relatively low doses of quetiapine are being used, an antipsychotic, for the treatment of insomnia. So I won't go through them all, but I do want to throw them all into the same group, which I consider to be sleeping pills, even though they may not come in the pill format. So how effective are the most effective of these sleeping pills? Well, the drugs that have had the most research in the area of insomnia in the last decade or two are the Z drugs. A large study looking at all the Z drug studies compared to placebo showed that you get to sleep a little bit quicker. The bottom line is that you can get to sleep maybe 22 minutes quicker with a Z drug than compared to a placebo. So if it takes you an hour and 22 minutes to fall asleep, you might be able to fall asleep in an hour with the Z drug. So it improves that time. Now that's based on polysomnographic studies, which means that you have to be in a sleep lab and you have to have all of those attachments to your head so that your brain waves can be detected to determine if you've fallen asleep or not. When you just ask the person, what time did you fall asleep? How long did it take? the improvement in that person's subjective experience is 7 minutes faster than with a placebo. So that's the advantage that people subjectively state is the advantage of a sleeping pill like one of the Z drugs, 7 minutes faster. Do they help you sleep longer? The answer is yes. They help you sleep longer over the course of a night. You get to sleep a total of 14 minutes longer. So in those placebo-controlled studies, there was 49 minutes longer sleep duration for the participants with the active medication. But placebo was no slouch. It gave you 35 more minutes of sleep in these sleep studies. So the net benefit for the duration of sleep is only 14 minutes. This is a picture of Canada showing the rate of chronic use of benzodiazepines from the different provinces in Canada. The average rate of older Canadians, 65 and older, who are considered to be, by definition, chronic users or long-term users of benzodiazepines is about 10%. The star province across our country is Saskatchewan at around half that rate of about 5%. You'll see Nova Scotia is about 16%. New Brunswick is our highest province, and Newfoundland is our second highest province. And we have some variations across the other provinces, as you can see there. So we have some work to do in Nova Scotia, and this is one of the reasons we're quite interested in engaging individuals to think about how they can improve their sleep without using sleeping pills. So that was some statistics related to the use of sleeping pills in adults, or in seniors. This image shows us the change in use of specifically the benzodiazepines and Z drugs over time in Manitoba. We don't have data in adults for all provinces like I did in the previous slide, but what do you see about the trend over time in Manitoba's use of sleeping pills, specifically benzodiazepines and drugs? And I think you'll agree with me, the trend is it's going up, not down. There was the impression that the use of benzodiazepines are going down, but really it's a replacement of the benzodiazepines with the Z drugs. So the Z drugs are becoming more popular, and if you only look at some sleeping pills, it may make the picture look rosy, but if you look at all sleeping pills, I would suggest that across Canada, we are not reducing use and have not been reducing use, but we've been adjusting what we've been using. So we call that substitution or replacement. So we will be talking about how to help people stop sleeping pills, but I just wanted to give you sort of a foreshadow of how that can look. We do not recommend the cold turkey approach of stopping sleeping pills when you've been taking them for an extended period of time. So what is an extended period? That could be a month, 2 months, or 3 months, but for many people, it is actually a year or many years. So in this example, you can see that the person was taking lorazepam, 3.5 milligrams a day. Some of it was during the day and some of it was at bedtime as a sleeping pill. And the plan was to help them reduce their dose gradually, in this case, over 11 weeks. But it doesn't have to be 11 weeks. It could be much longer. The time period between dose reductions doesn't have to be 1 week. It could be 2 weeks long, or in this case, we're now showing 3 weeks long. So there's no absolute rule about how fast to stop a sleeping pill, but we do generally recommend the longer you've been taking the sleeping pill, the longer the titration or taper period down. In some cases, for some individuals, it's a year or longer. So let's move on to talk about some of the adverse effects associated with sleeping pills. So a recent study came out from the US. Because of the interest in opioids these last 2 to 3 years, there have been an examination of coroner data related to opioids. And it was surprising to find that in seniors who had died in relation to opioid death. Now that might be an intentional overdose, but I think in most cases it was an unintentional overdose death with the opioids. In 2/3 of cases, there were sleeping pills also involved. So sleeping pills, when taken with other, what we call CNS or brain depressants, increases the risk of opioid toxicity. So we're quite concerned about the use of sleeping pills with a variety of other medications or alcohol or other things that slow down brain activity. What people often focus on with the risks of sleeping pills is falls. Fractures, hip fractures, visits to the emergency room, being admitted, surgeries. These are all very expensive, very time consuming. Nobody wants to be experiencing these kind of things with, for any reason. As we get older, the risk of falls increases. As we get older, the use of sleeping pills increases, and it sets up a perfect storm for the pills causing the injurious falls that cause people to visit the hospital, whether it's an ER or be hospitalized because of a fracture. There is also an alarming finding with the risk of pneumonia when taking sleeping pills. For people who have asthma or chronic obstructive lung disease or pulmonary disease, where they already have difficulties with their breathing, they are at higher risk of pneumonia. When you add sleeping pills into that mix, the risk goes up substantially. And in some of the studies, it was found to be between 5 and 20 times the risk for pneumonia in people taking sleeping pills who also have lung diseases. So we need to be wary of who we are giving the sleeping pills to for risks that are less well recognized, for example, pneumonia. Another thing that doesn't get as much discussion as probably we should give it is what are the effects on somebody's quality of life? So you may take a sleeping pill and not necessarily fall and cause a fracture, but you may feel somewhat unsteady. You may stumble. You may trip. You may fall but not injure yourself. And you may become less confident. You may withdraw from doing things with your friends or with your family. You may become more isolated, more anxious, more worried, more lonely. There is more research needed in this area, but the research that exists suggests that sleeping pills actually contribute to this. Another area that's been well studied is the risk of using sleeping pills and also driving. The risk for traffic accidents is estimated across different studies to be 3 to 6 times the risk compared to if you're not taking sleeping pills. Another well-known problem is that sleeping pills are not good for your memory. You cannot remember as well what you did the night before after you took a sleeping pill. For young people, they really should not study and take a sleeping pill and try to do an exam the next day. And for those of us getting a little bit older, we shouldn't necessarily use sleeping pills before an important presentation. But overall, what we see is they don't just physically impair us the next day, no matter who we are, they cognitively impair our abilities. Another item that we've seen on the news over the last few years, because several studies have come out, is the association with sleeping pills and dementia. Now, it's not clear if it is a causal link, whereas the sleeping pills are causing dementia, or if it is insomnia itself is more likely to be seen in somebody who is moving towards developing dementia, and therefore we get to also see more usage of sleeping pills. But there has been a link that needs further investigation. Next is the vicious cycle of the sleeping pills themselves. And we all know that no sleeping pill works equally well on its 5th night compared to its 1st night, or on its 10th night compared to its 5th night. So the effectiveness over time with regular use goes down and down and down. So you may increase your dose and it might help a little bit, but then the effectiveness goes down again. And then eventually you stop your sleeping pill and you go through a sleeping pill withdrawal syndrome. And the leading symptom of that withdrawal syndrome is insomnia itself. So what happens when you stop taking a sleeping pill and you experience insomnia? You believe you need to take that sleeping pill to treat your insomnia. But in fact, what you're experiencing is a withdrawal symptom of the sleeping pills themselves. So it's really important that we get the message out about the sleeping pill vicious cycle. It is to be expected that people who have used sleeping pills for a long period of time, that they will experience any one, if not several, of the withdrawal symptoms. And we try to gradually reduce and stop sleeping pills to help avoid withdrawal symptoms. So how do we help somebody get a good night's sleep and at the same time stop sleeping pills? So this is really what I mentioned at the start, the purpose of what SleepWell is all about. So SleepWell is taking advantage of the fact that cognitive behavioral therapy for insomnia is more effective than sleeping pills, safer than sleeping pills, and in the long run, less costly than sleeping pills. And I'm not the only one that believes that. The American College of Physicians in 2016 came out with guidelines on the treatment of insomnia in adults, and they recommend CBTi as first-line therapy for insomnia, and they clearly state that sleeping pills should be relegated as a second-line agent only to be used when CBTi has shown not to be sufficient or has failed to work for the individual. This guideline, I think, puts some wind in our sails to support individuals using CBTi, and now our challenge is to help people find how to get access to CBTi itself. It wasn't just ACP though, it was also new European guidelines that came out. So the European Sleep Research Society provided a very comprehensive guideline on the treatment of insomnia, and their primary recommendation really corresponded with the American College of Physicians guidelines stating that CBTi is first-line therapy and pharmacological interventions are not to be used until CBTi is shown to fail. So who is CBTi for? It's not just for people who have insomnia and nothing else. It has been studied in high-quality studies for people who have depression, pain, menopause, fibromyalgia, cancer, and so on. It's been studied in older adults. It's been studied in adults and adolescents. It's been studied when in a therapist's office that you're getting it as a group therapy with a whole group of people led by a therapist, or you're getting access to it by an online program or an app on your phone, or books that are created to help people learn how to use CBTi to treat their insomnia. So 15 years ago, it was very difficult to access CBTi because you would need to go see a specialized therapist for it. Today, you can buy a book, you can go online, or you can download an app and get started right away. CBTi has 5 components. We call them, with SleepWell, sleep drive, control, thoughts, hygiene, and relax. And they refer to the 5 components of CBTi as sleep restriction, stimulus control, cognitive therapy, sleep hygiene, and relaxation therapy. When you visit the SleepWell website, you can learn an awful lot more about each of these, but very quickly, Sleep Drive is really about starting a person on a brief period of concentrating or restricting their sleep so that they spend the amount of time in bed that matches the amount of time that their sleep diary says they are actually sleeping. You can't go to bed until your set sleep time, and you must rise at your set rise time. Once your sleep efficiency improves, then you can get into bed a little earlier, and as that goes on, you're getting longer and longer, more concentrated, more restful sleep. Stimulus control is something that a lot of us have probably heard about, where you need to leave the bedroom and do something very boring if you're not falling asleep. So you're in bed, 20 minutes later, you're still awake, your mind is racing, you need to leave the bedroom, go read a book, don't watch TV, don't use your phone to get caught up on world events, knit or any other thing that may help you relax, and then go back to bed. When you're ready to, if you're not ready to fall asleep 20 minutes later, you leave the bedroom again. Cognitive therapy is to help people learn about insomnia, about some of the myths around insomnia, and to help replace some thoughts that distract you from getting asleep, thoughts that make you more awake as opposed to more tired and sleepy. So it provides you with some skills and some insights, cognitive insights into sleep itself that will help people prepare before bed and while they're in bed to be able to fall asleep. Sleep hygiene, again, is something that many of us have heard of and we've talked about. It's very practical, it's very logical to help you stop doing the things that directly interfere with sleep and do more of the things that help to bring on sleep. So do vigorous exercise during the day. Don't do it right before bed. Avoid caffeine or nicotine later in the day or evening because they will interfere with sleep. Make sure that your bed is not too cold and not too hot. It's just right for you to fall asleep. That's sleep hygiene. And then there's relaxation therapy. It may be guided meditation, breathing exercises, and so on that you can learn. A lot of the resources that will support the individual to use these different components are available through SleepWell. What's really important is that SleepWell makes it easy for people to find the resources that they need to learn about CBTi. So SleepWell really is a portal to these resources. We are hoping that visitors to the SleepWell website will spend about 2 to 3 minutes on the website getting oriented and then dive right into what is called SleepWell Recommends. We recommend very specific books that have good quality and evidence to support them, and the same for the apps and websites that offer CBTi. So these are 4 books that are currently being recommended. Just so you know, we have no interest financially in any of the things that we recommend on SleepWell. So we're not for profit, we're academics, we're trying to support access to these kind of resources. We're preparing tools to help individuals use CBTi. So there is a SleepWell sleep diary. People can use it to identify through sleep restriction therapy what their set bedtime would be for a week and set rise time would be. And then they log their sleep according to what you normally log in any kind of sleep diary. And at the end of the week, you can calculate your sleep efficiency and total sleep time. To make it easy, SleepWell has an online calculator for these kind of things. But if you like to do the math yourself, there are directions on the SleepWell website for how to do the math. There are other wonderful resources that SleepWell recommends. So CaDeN is the creator, if you will, of a couple of these resources. Jenny will talk later about how you can get these resources yourself right after we're finishing here. So one of the most famous, if you will, is the one that's called the Empower brochure, which was studied in Montreal in a very good study that demonstrated that people who receive this 10-page brochure from their health provider are at much higher likelihood or probability of stopping their sleeping pills just because they've been influenced by the content of what's in that brochure and motivated to reduce and eventually stop their sleeping pills. Many of them received the booklet on the right, How to Get a Good Night's Sleep Without Medication, as a booster to encourage them how to change their sleep habits and improve their sleep health. We are doing the same thing right now. We are finalizing our booklets for how to get your sleep back, which is very much related to CBTi and helps people know where to access the resources that provide them with a full course in learning how to use CBTi, and then our version of how to stop sleeping pills. They'll be available on our website probably in September. So I think it's time for us to go to the SleepWell website. So Jenny, can you tell me about how much time I would have to orient people to the website itself?
I would say 5 minutes. Is that enough?
Yeah, that's great. So okay. I've just changed screens and it's loading. So the risk of doing any online orientation when you're doing a live webinar is that your screen will change quickly, that there will be no freezing. So I'm hoping that we'll be able to go through it quickly. So this is the SleepWell homepage. It is mysleepwell.ca. You can pull down and you can see that there is a quick access to SleepWell Recommends, because that's what we want people to do, is find out what they need to get in terms of CBTi resources and start using it. There's quick ways into learning about insomnia, sleeping pills, and CBTi. So since I'm talking about CBTi a lot, we'll go in this way very quickly, and you'll see how it's laid out currently. This will change, and in fact, it will be substantially simplified in the next 2 to 3 weeks, fewer questions. But I encourage you to come back after the webinar and take a look at the information that's currently there. So you can learn about what CBTi is, how it works, what's involved, what the 5 components are, for example. There's some descriptions here of each of the 5 components, what you have to do, so on and so forth. And then the key part is, how do you access? So this information, how to access, will become the priority. So we'll be moving that up. I'm just going to click on SleepWell Recommends here, but there are a variety of ways to get to SleepWell Recommends. And then you will see our list of curated resources. So we really looked at hundreds of resources that are available as books, as apps, or online. The vast majority of them do not offer the full meal deal, if you will, of CBTi. They may do one thing or another. They're not evidence-based. They're not research-based. So what you see here are those things that include all components of CBTi and have been studied, demonstrate the effectiveness of them. So at the top, there is SleepEO, which comes from the University of Oxford in England. There's Shut-Eye, also developed through some US universities. Go to Sleep, which is from the Cleveland Clinic. CBTi Coach, which is another US resource. It's free. It's really the basics, but people might want to start there if they're interested in apps. And then there's the books. Our only Canadian book, which we're very supportive of, is from a Queen's psychologist, Think Into Sleep, and then some other books which are also of excellent quality. So that's the short list. The difficulty people will have is picking one. So we don't want to give an awful long list. People can pick if they want to go with an app first, or a book first, or to go online and start the program online. People will improve their sleep usually within 2 to 3 weeks of starting the program, and the program often takes about 6 to 8 weeks. It's rather modular. It's like going through chapters 1 week at a time. So that's the really important component of SleepWell, which is going into getting the SleepWell Recommends, but there's a lot more information about CBTi itself. As I mentioned, there is a sleep calculator. So I'll quickly show you that. You fill in your sleep information, you click calculate. It tells you how many, your total time in bed, your total time awake, your sleep efficiency, and your total amount of time sleeping. And then it gives you an idea of what is ideal sleep efficiency. And if you're less than 85%, you've got some room for improvement. But if you're above 95%, it might mean that you're not giving yourself enough opportunity to sleep. I've shown you the sleep diary. I won't go in there. There's a sleep hygiene checklist that's dynamic. You can print it off and take it into your health provider. There's an insomnia beliefs quiz that will help with cognitive therapy for insomnia. So answering those questions, that can also be printed off and taken into your health provider. And I'll just do a very quick introduction to what we have about sleeping pills. There are 6 sections. There are quizzes, so they come in questions of 5 at a time. You can do more than one quiz to see what you know about sleeping pills. There's information on dangers, the vicious cycle that I oriented you to, and then information on how to stop. There's a little bit of history about sleeping pills that goes back to the dawn of time and up to the very present. And then there's a tool that helps people receive guidance and plan their sleeping pill reduction and eventual continuation of it. So I'll just quickly show you the dangers, and you probably recognize some of the similar features that were in my presentation. They are also similar features in the booklet that we are creating. So this will be updated somewhat, but it should look similar to this in the next few weeks once we've updated this a little bit. So that's what people will see to come to our website to learn about sleeping pills, and in this case, the dangers. I think, Jenny, I'll probably end there. I'll just pop back to the last slide, which is for completion's sake, and send it back to you. Shall I unshare my screen now so we can go back to you?
That would be great. Thanks so much, David. That was a very interesting presentation. Awesome. So I'm just going to share my screen now. Here we go. So as David mentioned briefly, CaDeN has a number of resources, and we're trying to raise awareness across the country to healthcare providers, to community organizations, to the public, to governments, about a whole host of medications, including sleeping pills, the risks and benefits, helping people weigh these. And all of these resources are available on our website at deprescribingnetwork.ca. You are welcome to download these brochures, posters, fact sheets, articles, to share them with your organizations, to use them within your practice. And also, if you would like to order hard copies of these materials, we'd be happy to send them to you. So please, if you'd like hard copies, explore our website, figure out which ones you'd like to have for your work, and email us at info@deprescribingnetwork.ca, and we'd be happy to get them to you. So thanks very much. Now, I'd like to start the panel discussion part of our webinar and bring Bill Berryman and Dr. Andrea Murphy into the conversation. So this is the time also when everyone, you're welcome to ask questions of our 3 panelists. And we'd ask you to please type your questions into the chat box if you have any, and I'll try to get to as many as I can. So I'll just start with a question for Bill. So Bill, I know that health is often seen as something that's managed by the government. It's a big structure, and it's something we feel that is really difficult to change and affect. And I'd be curious to know whether seniors organizations can play a role to improve the health of seniors, and how you feel about that.
Well, first of all, I'd like to talk a bit about the Seniors Advisory Council for Nova Scotia. We are a group of 9 seniors organizations representing 120,000 seniors. We meet on a monthly basis with the Deputy Minister of the Department of Seniors. Our expenses are paid for by the Department of Seniors, and we've been meeting on an ongoing basis since 1995. I was very fortunate to attend the conference in Montreal on deprescribing, and at that conference I met Dr. Gardner, and I asked him to come and speak to my group, and he came and did a presentation similar to what you saw today on April 26th. We meet on a regular basis with the Minister of Health and Wellness, the CEO of the Nova Scotia Health Authority, the Deputy Minister of Health and Wellness. So we do have an opportunity to bring these kind of issues to their attention. But we're fortunate because I think we're the only province in Canada which has such an organization that meets. And the other thing I think that's important is that the federal government just announced a new Minister of Seniors. And I've written a letter to her asking for a meeting. And one of the things I want to talk to her about is deprescribing. And also one of the main concerns we have for the Association of Retired Teachers in Canada is a national pharmacare program. So I'm hoping to have a meeting to bring these kinds of things to her attention as well.
Oh, that's fantastic. So I guess you would say that yes, seniors organizations can have really impact health, the health system, and the health and well-being of seniors. They really have a role, from what you're saying.
Well, the other thing too is that you know, I think it's important that seniors meet other organizations similar to the Alzheimer's Society, to Caregivers Nova Scotia. We meet with them as well. There's other organizations that are very important that have the ear of government and also have and can speak on behalf of seniors. But we found in the past few years, because when the government tried to make some changes with seniors pharmacare in 2015 and the public reacted very strongly against it, I think they're now realizing that the seniors have a strong voice and they should listen to them.
Yeah, great. So I know you've been working to support the well-being of seniors through different initiatives over the past decade. But more recently, you have started including medication safety and deprescribing in the things that you're really working on. And I'm wondering if there was a moment or something that made you realize or want to start working on medication safety for seniors as well as all the other things.
Well, I think there was a panel discussion where there were panelists who were given 15 minutes to give what was called their elevator speech. And that is when I first heard David speak. But I also heard some very important individuals speaking on behalf of other issues, the opioid issue in Manitoba, seniors issues from other provinces, how some of them are trying to deal with the government. So I left there thinking we have a serious problem here because I don't think seniors understand the issue with the polypharmacy. And so that's why I said to myself, I think I need to bring Dr. Gardner in to come and speak to us and do a full presentation. And then based on that, let's see if we can move forward and bring this kind of information to the government of Nova Scotia. And the other thing too is that one of our 9 groups in our Seniors Advisory Council is Retired Doctors of Nova Scotia. And so I thought it was important that we brought them on side, because I know that the one individual in particular is very strong on and doing presentations on choosing wisely. And that's one of the parts where they're trying to bring to the attention of general practitioners the problem with the overabundance of drugs.
Okay, thank you, Bill. Now I'd like to bring Dr. Andrea Murphy into the conversation, and I have a question for Andrea. I know you come to the deprescribing and medication safety awareness movement as a clinical pharmacist, teacher, and researcher, and you've created several programs that support mental health. I'm wondering if you could talk a little bit about your experience with deprescribing in older adults and what made you want to work in that area.
Thanks for that question, Jenny. Yes, I think as many pharmacists in communities could probably relate, I think just seeing people struggle with issues with insomnia, but then also when they are taking sleeping medications for a prolonged period of time, it can be very, very challenging to figure out how to stop the medications, you know, just even in terms of tapering and the adverse effects that can be associated with that. And I think for me, the challenge, it's always a challenge when looking at a lot of co-prescribed medications and trying to determine, you know, how even a tapering regimen might actually impact people's other medication regimens and in general, their quality of life. And I think just seeing the significant concern from the client or the patient's perspective, which was something that really inspired me to say, there must be other ways and mechanisms that we can help people. I think we've known about, you know, the issue of polypharmacy in older adults for a very long time. And I think as David and I were trained as pharmacists, it's not just about deprescribing, but it's always asking, is this medication appropriate for this person, given the context of their health and other medications? So being mindful of that and thinking about whether or not it's appropriate right off the bat. Another thing that we're always taught is when there's a starting plan, is there a stopping plan for a medication? So I think these things ring true to us from a principled approach about how to care for patients. And I think that, you know, deprescribing, whatever word you want to use, it's always probably been a part of our philosophy of care. And now we're saying, what are the other ways that people can get their sleep back, you know, in addition to potentially medications, which aren't always the best option, but what are the other options available, and are they accessible to people just because of the problems that we've seen with them over time?
Right. Thank you. Now, when I've spoken to the public about these issues, I often hear people say, I hope you're telling doctors about this as well as us, like seniors and community organizations. And I know you've worked with family doctors, and I'm just wondering if you could tell us a little bit about some of the challenges for family doctors around deprescribing.
Yeah, it's a very interesting question, and there's actually a lot of literature in this area looking at the factors that impact family doctors in terms of their prescribing of medications like benzodiazepines and Z drugs. And very interestingly, I was just reading a qualitative study a couple of days ago where they had interviewed general practitioners, and the issues, it was a study from New Zealand, but all the way across the world here in Nova Scotia, the issues are very similar. There's concerns that, you know, doctors want to make sure they're doing the best practice for their patients. For people that have been on them long term, at times there can be issues with not knowing how to stop, or are they jeopardizing their patient-doctor relationship if they were to discontinue the medications? A problem that was also brought up in the study, that is one that we commonly encounter here in Nova Scotia, is that a medicine might be covered by a drug plan, but then other alternatives may or may not actually be in fact covered. And so when someone is trying to seek out an alternative, whether it be CBTi, or maybe they did want to have a personal coach or talk to a psychologist about their sleep issues, that might not actually be something that they can afford. So I think from the accessibility issue and thinking about affordability, all these factors also play into the equation. So I think if you ask any physician, pharmacist, nurse practitioner, you know, emergency room doctor, you know, what is this problem or issue really about? And they're going to say, well, it's really, really complicated. It's a complex issue, and there's multiple variables that can contribute to it, both the initiation and then, you know, challenges with the deprescribing.
Right. Okay. So maybe having patients and the public know about it as well is important, but it's actually, I mean, much larger than even that.
I think you're right. There's bigger system issues as well that are coming into play. And I just noted that somebody did comment as well on nurse practitioners as prescribers, and you're correct, in Nova Scotia they can prescribe controlled drugs and substances as well. So it's multiple disciplines across multiple layers of the health system. I think that this issue actually touches.
Right. Wow. We're starting somewhere, but there's a lot to be done, I guess. Now, I noticed that someone wrote in the chat box, could someone please speak to the challenges of caregiving and sleep? For example, sleep interruption, caregivers sleeping with one eye open. Yeah, maybe Andrea, would you have any experience with caregivers?
David might. I don't have a lot of solutions to this, but I know that some of the people that I've worked with who are clients that have also serve in a caregiver role, we're often looking into other aspects of their life, whether there might be respite or things available. Are there other family members that can help? Sometimes people don't feel like they can ask for additional help. So often it's not just thinking about the immediacy issue of having difficulty sleeping and getting a quality sleep, but what other supports are available to that person that might actually help them fill in some gaps to actually get some good quality sleep. But you're absolutely right that it's such a challenging situation. And often it's not just the sleep issues that go along with it, but stressors. So thinking about what are other supports in the person's life to help with the stress of being a caregiver, not just during the night and missing out on sleep, but also during the day, and trying to think about more holistic approaches, which isn't an excellent answer. I recognize that, but it can be a very complex problem.
Yeah, I was just going to add that no matter what I say, I think it won't apply to everybody. So it's really important for a question like that for the individual to speak to their health providers and explore opportunities or support groups. So there's Caregivers Nova Scotia as a support group where there may be people who have had the exact same issues, have good solutions for them. So Andrea or I giving sort of a higher level answer probably isn't sufficient for the individual person. But I would like to mention the risk of sleeping pills. Whether you are a new parent or whether you are taking care of your elderly partner, there is a risk of using sleeping pills. You can't sleep with one eye open, as the person has indicated, when you're using sleeping pills. You can't rely on being awake and aware and alert right after you have taken a sleeping pill. So the use of things where you can snap out of sleep, such as CBTi to help you get into sleep, may be much safer and more appropriate for someone who does need to get a good night's sleep when they can, but also be ready to be wide awake when they need to be.
Thanks, David. We have 3 minutes left, so I'm going to try to fit at least one quick question in. I'd like to ask Bill another question, and I'm just wondering if you have any recommendations or advice for others who'd like to get the word out about medications that can be harmful and their risks to seniors in particular. Would you have any recommendations for people?
Well, what I did is after the presentation by Dr. Gardner on April 26th, I contacted you, Jenny, and asked if I could have some written materials to pass out to my members, and you graciously offered materials for me. So I decided I had an annual general meeting coming up on May 15th, and I would do a short presentation on deprescribing to them. And I asked the group if they would like more materials, if they would like more reading materials. I have 23 branches in the province, and 14 of those branches have requested materials, and you have sent out 780 copies of 5 different booklets, 3 of them which you showed today, to my members. So we will now be using that information when we have business meetings with our branches. I've also offered the other 8 groups who comprise the Seniors Advisory Council that there's materials available, and given them your name and address. So I would expect that they probably will follow up as well. And the other thing too, we did have a presentation at our recent Canadian Association of Retired Teachers on deprescribing from Dr. Barb Farrell from the Briere Institute. So we now have 13 retired teacher affiliates across Canada who now have heard this particular presentation. But I think it's really important that we do an education of our members. I know that the media picks up on the opioid crisis, and that's what the doctors and the Department of Health and Wellness seem to focus on. But I think that we have to get the message out there that we have a serious problem with sleeping pills. And I think the statistics that David showed are quite astounding. And there was an article in our paper on July the 10th from the Chief of Emergency Medicine at the Halifax Infirmary. And he said, we have a bit of a crisis and the medications are now associated with falls. And he said in a recent interview, signaling out anti-nausea drugs, antidepressants, and tranquilizers, and sleeping pills. So I think the medical profession now realizes we have a problem. And it's quite interesting. I spoke to my own personal physician about the presentation I heard in Montreal. And in this particular little community I live in, we have monthly newsletters, and the health tip for the month of June was sleeping pills are usually not the best solution and provide information on tips for better sleep. So I think, number one, we need to talk to the physicians. We need to talk to doctors in Nova Scotia. We need to talk to the Department of Health and Wellness. We have to get that information out there. Otherwise, I can see a major crisis as Nova Scotia's seniors become older and older. And what I see, a lot of problems with polypharmacy.
Thank you very much, Bill. Okay, so it's 2:01. For those of you who need to leave, thank you very much for your time today. We really appreciate you participating and joining in. It really means a lot to us. I have a poll. I'd love to get your feedback. So for those of you who can stay another couple of minutes, we'd just love to know, it should pop up on your screen now. We'd love to know a few little things about how we can improve and what other topics you'd hear about. This is confidential, so we won't know what you respond. Now, Andrea and David, would you have time for a final quick question, or? Sure. Okay. So this is pretty broad, but I'm just wondering what you feel needs to happen in Nova Scotia for there to be a significant decrease in the number of medication-related harms in older adults.
Well, we're very impressed by the findings of the Empower brochure. And so what we really would like to do across Nova Scotia is share information that is developed and designed specifically to provide people with the opportunity and the capability and the motivation to reduce their sleeping pills and replace them with an effective, safe, long-term therapy, CBTi specifically. So we would really like to be able to do that on a population level of people who live with insomnia and who have been using sleeping pills for the long term. I really support Bill's approach to this. He has a lot of influence across seniors as well as politically, and our job would be to design the research around any kind of interventions, programs that we develop, for example, SleepWell, to see how they can reduce the use of sleeping pills. And then we can measure what kind of benefits are people getting in terms of their sleeps and what kind of harms are they avoiding, for example, visits to the emergency room, walk-in clinics, or being hospitalized for the harms that we know are associated with those sleeping pills.
Okay.
I would just like to add a plug to say that I think collaboration is key. So I know your question was more about what do we have to do, but I think that how we do it is just as important. So I think having folks like such a strong advocate and other folks like even our Drug Evaluation Alliance of Nova Scotia, you know, within government, like there's so many different players in this issue. So I think having everybody at the table who's willing to work is pretty critical. And I think in Nova Scotia, there's been a good, I guess, petri dish of kind of activity that's been growing. So it is really good to see that. So and I think we're fortunate to have people like Bill, you know, that are so outgoing and effective and advocating so much for these particular issues, because a lot of times I think things do really have to happen from the ground up as well.
Yeah, great. Thank you. Yeah, we'll all keep working, I guess. So just wrapping up, I want to thank you, the attendees for joining in. We really appreciate it. I want to thank Bill Berryman for taking part today and for all the work he's doing to raise awareness. We really appreciate it. And I want to thank both Dr. Andrea Murphy and Dr. David Gardner, who are executive members of CaDeN, for those of you who missed the beginning, and who do so much work with our organization and on their own projects to support the well-being of seniors and Nova Scotians, Canadians. So thank you, everyone. Don't hesitate to be in touch if you'd like to take part, and I'm signing off. Okay. Thanks.
Bye. Bye.